So we have a small group today. Were you guys able to get your clinical schedules yet?
Not yet.
Not yet.
Okay.
Yes,
I got it. I got my clinical schedule.
Okay. If you don't mind in the comments, or you can send me an email, I just kind of want to get an idea of what days you guys are doing clinicals so that we can set a finalized date for our lectures. So if in the comments you can just type in like what day you guys are doing it.
I'm going to make it right away to you.
Okay. Okay, perfect. And I'll just take note of all of this so that I can look and try to accommodate. Like I said, I hope that I can fit everybody's needs and get everybody so you're available to come. If not, and there might be some days or some weeks that we need to change things up again. We might set it for a Wednesday, may need to do it on a Thursday, just depending on our schedule. So we'll try to get it as permanent as possible, but again, we'll kind of play with things and see how it goes. Looks like a majority of you guys have Mondays, so that's good. Okay, and then a Tuesday. So hopefully there's like, a Thursday that works best for everybody and you don't have anything going on. So we'll take a look at that and kind of finalize that hopefully by the end of the week so that way next week we can kind of move forward and have a set date, okay? How's everybody's first week going? How do you guys feel like the readings, are you guys able to navigate through Blackboard pretty easily? Everything kind of making sense?
Yes, I think I only had one question though. So do we only have that one quiz for the modules on Blackboard?
Yes,
okay.
So there was some confusion.
Another portal.
Yeah, sorry. I think I have a delay here, so I apologize if I'm talking over you. So yeah, there was an error in the due dates for the quizzes, which caused some confusion. Your quizzes, and those should all be updated as far as what the due dates are. So all of your quizzes, so each week you have week 1, module 1, week 2, module 2, and so forth. So every week, your week starts on a Monday and ends on a Sunday. Sunday night at 11:59 p.m., your quiz is due. So you have all week to prepare. You can log on. You can take one question and save it and then go back and complete it. And that's kind of how that works. My suggestion to you would be take the quiz. This is kind of going to be your, I don't want to say easy points, but try to maximize your points for your quizzes. You can get 100%. It's open book. It's not timed. You kind of do it on your own schedule. So make sure you have all those resources available and make sure you have your readings done, because if you're going to try to take that quiz and not have any reading done, you're putting yourself for not getting as many points as you possibly can, right? So that would be my suggestion to you, and take it later on in the week after you've read, after you've done some practice questions, after you've done even lecture. Okay, so again, figure out what works best for you and your schedule. But yes, every Monday at 11:59 they're due. There was another question. Have you guys been able to access your online Evolve resources for the case studies? So in Blackboard in each module, so if you click on module 2, we kind of went over this last week, but it goes over the outcomes. So I would definitely know what outcomes you're looking for. It has your readings there. There's also some presentations within there, but towards the bottom, there's one topic that talks about practice case studies and clinical reasoning. And for module 2, there's case study 25. I sent an email out to you guys last week that kind of highlighted some snapshots on how to access all of that. Sorry. And so it would be a good idea to start doing that now so that you can get those case studies in, and making sure that you kind of get that whole full picture of what's going on, okay? Mo, you thought what was 15? Case study 15? So go back to Blackboard, and if you're on module 2, towards the end, the clinical reasoning is case study 25. So I'm going to show you guys again how to access your Evolve account. So Let me, give me 1 second here. Okay, see if I can share my screen with you guys. Okay, so when you log on to your Evolve account, right, you got a couple options here. Go to your catalog. Where is it? Your My Evolve, sorry. These, when your books are loaded in here, these are going to be your resources, okay? So this is really where you want to go for anything other than your reading. When you want to do your readings, you're going to go here to your library. In your library, you're going to have your books, okay? So for the clinical case studies, you're going to go to your Evolve resources. When you click on here, and yours might look a little bit different here, but you're going to go to your student resources, okay? And then here within everything is the chapters that it's referring to. So for chapter, so that's not what you're supposed to be reading, because that talks about respiratory. Is that what you guys see on your end too?
We're not able to
When you
see your
log on?
screen right now.
Oh, you're not? Can somebody
Yes.
log on to their Evolve account and look at your resources and
I
tell me
am,
what
and
chapter?
that is what I'm saying.
Does it say
105 is
respiratory?
respiratory.
Okay, so that's
Yes.
incorrect. Okay, so I need to update that too.
Under which book should we be looking? Because I have the Lewis book, the nursing care plans, and the psychiatric book.
So that is reflective of the Lewis book, those
Okay.
case studies. So, okay, so I need to fix that. But if you go, you guys can't see my screen?
No.
No.
Let me try.
No.
Okay, let's see. Okay, I don't know, I can't get it to show. You guys still can't see my screen?
No.
Okay. When you log on, it'll have, again, you'll go to your student resources, go back to that email that I had sent you guys, and it'll have those screenshots for you. In the chapters, and I'm going to have to fix that, there's stress management is listed under chapter 6, and sleep disorders are under chapter 7. So when you click on each chapter, it'll give you review questions on the very bottom. So there's at the very top, it says answer key for your review questions. It'll have an audio glossary. It'll have key points and answers. That's the one that we showed last week that kind of highlights the chapter. I would definitely go back in after you read and go over that as well. So I'd say after every reading, when you're done with your reading, go back into your resources and review this, okay? That will help. And then again, there's some review questions for you guys. And I think this one, and you can go in as many times as you want and take those questions. So I'm going to update that as well too.
So is that the case study you're talking about, or where is the case study located?
So they should be in your resources in Evolve. You also, you know what? Hold on, let's see. Hold on 1 second. Let me go back into Evolve here. Do you guys have your case study book as well? The clinical reasoning? Is that loaded onto your, okay. So let's see if that's what they're, I think I only have access to the instructor view. Can somebody log on to the clinical reasoning resources?
We don't have that book in our Evolve. We only have the physical copy.
Okay. Okay. So you guys should have that on loaded on. So I'm going to reach out to you and see if we can get that loaded onto your accounts.
And I don't believe we have
and
access to the case studies under our Lewis book. We only have the like the summaries and the review questions. We don't see the case studies.
Paige, are you able to share your screen with me and show us what you're looking at? If you go, actually, hold on, let me make you a moderator. Okay, so if you go down to the bottom where there's like a little box and an arrow, it says share content. When you click on that, there's also another little area that says share application and screen. If you click that, you'll be able to share your screen with us when you're on your Evolve account.
Okay, can you see it?
Yep. So go ahead and, yep, there you go.
So this
click
is
on
my Evolve account. And I have these 3 books, but I don't have the clinical reasoning one yet.
So
If
click
I
on
go
that right
to-
there. And then go there. And then go down to the bottom where it says review questions. So these are the questions that you guys can go over. These are going to be practice questions from each module. So you can go through here. You can see at the top there's 13 questions on each one. You can go through there. When you answer, it'll give you a score. And then if you go back out, so click that back arrow. Yep, get out. I'm going to get out of there. And then at the very top, you see that says answer key for review questions. So you can click there, and it should give you the rationale for everything. Yep. So there's your answers to the questions and your rationale for the answers. So I would highly suggest going here after every reading when you do your chapters, is go in here and take these questions. Okay. A couple of things. It's going to help you review the chapters that you just read. Okay, and it's also going to help reinforce how to take or answer the questions. Again, I can't stress enough how different nursing questions are. And you really want to prepare yourself for that first exam. Okay, so take as many practice questions as you can. So go back out to that page where it gives you the options. And you see down on the 4th one, it says key points and answer keys. If you click on that, this is kind of a summary of the reading. Okay, not a complete summary, but the highlighted areas. So this is you can kind of use it as a study guide. I wouldn't replace your readings by any means in here, but use it to kind of reinforce, again, your readings. It'll kind of give you the definitions of things that you're looking for. So again, kind of just a highlighted area, okay? So that's another resource that you have. So go ahead and click out of that. If you like auto books, you can have that auto glossary there. So those are the things. That conceptual care mat, click on that. Let's see what that does. Let's go to create a map. This is a new little feature that they've offered. So this looks more like a care plan. So if you guys in your clinicals, when you're doing, and we also, there's a sheet in ATI that does the same thing. This looks like it could be helpful for you. So as you're going through your readings, you can definitely, or you have a patient that has these specific history or diagnoses or anything like that, you can definitely use this to help in your clinical patients. Okay, so you can see over on the right has the lab values, it's got treatments, it's got your assessment data and all of that. So this could definitely be helpful and another tool that you guys can use. So definitely look through your resources, know what they are, and again, each module you want to make sure you go back in and review those review questions, okay? Go back out to the Evolve where you have your books listed. So click on that nursing care plan one. Actually, is it care? Go, hold on one second, let me see something. Yeah, you need the clinical reasoning book. Okay. So you got your psych, okay, so your Varicarialist, that last book there, that's your mental health book. Okay, so in some of the readings, you're going to have some readings from there as well too. So I believe you had some for chapter 2. You had chapter 10 to read. The chapters are really short, so make sure you get that reading done too. And to get into your readings, go back to your, scroll down a little bit. Oh, you guys don't have your ebooks loaded, you said, right?
No, we don't.
Okay. Okay.
We should be receiving the physical copy though, sometime this week.
Okay, but you guys do have the physical copy of the clinical reasoning, correct? For the case studies?
Yes.
Okay.
Yes.
So can one of you guys, I don't have that book with me. Can somebody open their book and just see what case study 25 looks like? Is it related to module 2?
Yes, it's talking about stress and snoring
Okay.
and sleep disorders.
Perfect. Okay, so going back to what we were talking about in Blackboard is that practice case study 25 is in that book, that clinical reasoning book. So it's not in your Evolve book. I apologize for that. So go back in, and that's something definitely, again, case studies, and we're going to go over a couple today with this module. It really helps you kind of go back into your reading and pull that information that it's asking you. So it'll ask you more questions, not per se like a A, B, C, D, E answer, but how are you going to think through what they're asking you? How are you going to get to a resolution on each of your patients? So it's really good to get that practice in. It'll definitely help you understand the material better, okay? So, all right. Well, thank you so much, Paige, for sharing your screen with me. Case study is gas exchange. Are you, Heather, are you in your clinical reasoning book? You have the physical book.
It does talk about some gas exchange, but it's generic questions about the type of sleep apnea and 5 signs and symptoms. So it's not asking specifically about the gases. That's just information included.
Okay. And so again, so when we talked about module 1, now we're going to go on to module 2. Each piece to that puzzle is a platform to build on, right? And so that's a perfect segue to, when we talk about sleep apnea, how that affects the respiratory system, right? Even though we haven't gone on to the respiratory system, you'll kind of have a foundation of what that looks like, what sleep apnea and how that affects that, right? So when we get to that module, when we talk about that, you'll kind of be able to put that picture together. So again, everything's kind of a little building block on how we're going to, go through every system and the, the basic disease processes. So some of those questions are going to be a little bit more than what we've gone over. And you might not be able to answer them, but just answer them the best that you can. Again, they're practice questions. You're not getting graded for them. Those won't be on our exams or your quizzes. So, just kind of think through that process and answer it the best that you can. Okay, so that makes sense. All right, so, okay, we kind of got over Blackboard. You guys should have all of those emails. Look at your announcements, and I'll update that case study email as well. Just making notes for myself. on how to access that. So you guys got lots of resources. I'm sure I even sometimes have to remind myself how many resources you guys have. If you are feeling like you need a tutor at this point, and you may not kind of be able to judge that right now, but if you're having trouble, you know, taking the information and being able to apply it, you're not doing so well on the quiz, or you're not able to answer the study questions and get a good result, I would definitely reach out sooner than later. That way they can help you. You know, is it a study habit? Is it how you're reading? What information you're actually pulling out of the readings, that type of thing. So you can get a handle of it before the exam, okay? The last couple of semesters that I've taught, the first exam is tough, not because it's content heavy, but because it's new for you guys, right? And so it's really getting a good understanding on, again, how you're reading, what you're actually, you know, obtaining from those readings and how you're applying them. So again, do all of the practice that you can so that you can do well on that first exam. Okay. Once you hit module 5, it's content heavy from the here on out. Okay. So really get this, understand it, know it, and do as best you can. Okay. All right. And I apologize, my throat is super scratchy today, so I might have to take sips of water here every now and again. All right, so let's dive into chapter 6 when we talk about stress management, right? So I think everybody's very familiar with what stress is, right? So just how we all individually cope with things, how we treat our mental health, right? How our emotions respond to the stressful event, right? So you can imagine when you're talking about a patient in the hospital, that how that would trigger a stressful event, right? Not only for the patient, but probably for the family or the caretakers, right? So you kind of have a lot of emotions going on. What's happening to that patient? So if you look at somebody who's not able to cope, and they're in the hospital and they're your patients, what's a couple of things that you might notice with that patient? How would you approach that patient? What would you see?
If a patient is not coping well, they could be like pacing or biting their fingernails or sweating.
Mm-hmm. What about that patient that when you're talking to them, they don't make eye contact or they're not really involved in their care, right?
Mm-hmm.
They could be completely like disengaged. So you're trying to educate them or trying to, you know, help them cope with what's going on, and they're not hearing you, right? Because they're so focused on whatever's bothering them or whatever they're anxious about, right? Whatever they're stressing about. So they're not taking in information. Is that the appropriate time to give them education?
No.
Absolutely not.
Right, because they're not hearing you, right? So it's really good to be able to identify that, acknowledge that. What are some things? So let's say you're in a pre-op area and a patient's really nervous because they're getting ready for surgery. So you're on a schedule, right? So you got to keep that schedule so that all patients can have their surgery appropriate and everything's not getting backed up. But you have one patient that's sitting there and is super anxious and has a ton of questions, right? You want to make sure you're addressing them and not ignoring them, but you also got to keep on that schedule. So what are some things that you can, talk to that patient? What would be the first thing that you want to ask them?
Well, I think you could ask them what's concerning them and be really positive with them. Tell them all the positive things that will come out of it, kind of walk them through what you'll be doing, but really positive so that they feel like your comfort and knowledge about this so that they won't be as stressed.
Yeah. So you really want to, tell me more about what's going on. So you don't want to assume that they're, it could become something completely different, unrelated to the surgery, right? Maybe something happened before they got there or something like that, So you always want, we're investigators, right? So we're always trying to dig and trying to figure out things, right? And so really your first approach to that is, tell me more. Tell me what's going on. What's your biggest concern? How can we let's talk about this, So how they deal with their stress is critical to everyone's well-being, right? And so, and again, us as nurses, it's important for us to help them find the tools to manage their stress, right? We might not have all the answers, or we might not be able to give them what they want to hear, but we can help them kind of, put things into categories, right? So let's talk about, you're worried about surgery, so let's talk about that. And then maybe they're concerned with the outcome. What if they're not able to do all their ADLs? Who's going to take care of them? So that's, let's talk about this now, the right now, and then we'll address that, when it comes to that time. So you want to, and especially if they're one that can't handle or deal with a lot of things at once, right? You don't want to give them too much information. So their perception of stress can be very different. That can definitely influence the way that a patient responds, right? And then you have two different types of stress, okay? You got the psychological, and then you got the emotional, right? Which can be positive or negative. So many different factors can play into that, okay? So for instance, give me one example of a positive stressor, something that's positive. Something that
Exercise.
you're happy about. Okay, exercise.
Anything new, like a new relationship or a new home or something that's a positive change, but it still brings stress on you.
Absolutely, absolutely. So yeah, so those are great examples of positive stressors. They're positive things, they're great things, but definitely, oh my God, how am I going to manage all of this, right? Give me some negative examples of some psychological factors.
Like maybe a death of a family member.
Right, exactly. Yeah, death is never easy, right? You go through all those grieving stages, so it kind of lingers. Right. So, okay. So again, it's all about perception, right? So you have a stressor, right? So if it's physiological, so pain, right? So somebody's in a large amount of pain that they're not able to control, that can definitely trigger that stress factor, right? It's their perception on it. So you might have that real stoic patient that could have, they tell you to have 10 out of 10 pain, and you can't even tell, right? They just look completely like they got it together. And then you might have that other patient in the other room who says their pain's 2 out of 10 and needs that pain medication and is thrashing throughout the bed. They probably won't tell you it's a 2, but nonetheless, completely different responses, right? With the same, you know, let's say they both told you 10, right? Because we want to keep it even. Someone that's stoic and someone that's, thrashing throughout the bed, that's requesting pain medication. It's their perception and how they handle that pain, right? How they perceive that pain, which is going to definitely trigger that stress response, right? Another thing physiological is excessive noise. So hospitals are noisy, right? People come to the hospital, they're not feeling well. That stress is definitely elevated. They're not really sure what's happening. They're waiting for, they could be waiting for a diagnosis. It could be the family member that's there as well too. That's kind of helping create that stressing environment. But definite noise in the hospital. So we try to keep it at a minimum, especially during the sleeping hours, right? Because we don't want to disrupt that sleeping cycle, or try to keep it as normal as possible so that they don't have other issues with that. And we'll talk about the sleep here in the next chapter. But excessive noise, okay? What's another physiological stressor that could occur with our patients? And you guys can use the chats too, Anita. We talked about pain. Oh, I saw you're failing your exams during. Absolutely. That's definitely a negative stress response, right? Getting a bad diagnosis. Infection. Heather, you're absolutely right. So an infection, right? So again, a majority of your patients are in the hospital because they could have some potential infection going on, right? So that's definitely something that was going to cause that physiological stressor, okay? So more of, let's see. So an emotional stressor, right? We talked a little bit about that. So give me some examples of an emotional stressor that somebody might be going through. A bad diagnosis? Absolutely. Yep. Generally feeling anxious about the hospital and what it can mean for them? Sure. A lot of people, you'll see this quite frequently. They'll tell you they don't have any medical problems. I've got nothing. I'm not on any medication, right? And let's say they're 65. They're in the hospital because they have high blood pressure, high cholesterol, they have just had a heart attack, they have an undiagnosed diabetes, and so forth. So they got this long laundry list of medical problems that they're completely ignoring, right? Because one, they don't want to deal with it. It probably is a very, very big stressor in their life, right? And so the other thing is that they don't like hospitals. They do not like them. They have what's called white coat syndrome, and that's really a thing, right? Anybody that comes into the hospital, their blood pressure immediately shoots up. Their stress responses, they get real sweaty, for really no reason, right? They're just there, and they see that, and that causes that emotional stressor factor. Okay, yeah. Fear of anesthesia, right? So there could be all kinds of different reasons, right? Everybody has their own perception of different things. So again, it's our job as the nurse to be able to identify that, right? So that we can help them manage that, so they don't, cause other issues, or, get their blood pressure through the roof, or cause their diabetes to get out of control, or that type of thing. So we have to help them acknowledge it and help them try to manage it, okay? Or at least talk about it. All right. So again, we talked about good and bad stress. So happy events can be stressors, right? They can be motivating, they can be inspiring, and they can also be something that causes people to become depressed as well. Okay, so again, there's good and there's bad. It's perception, and how they manage it and how they deal with it is how it's going to evolve. Okay. Vasovagal be one. Sabrina, what are you relating, or what are you talking about with that?
Oh, I just meant the response. I don't think I spelled it right. Just when you get like a shot, or people get a certain stress response, their body kind of freaks out after getting blood drawn, or they just kind of get that sweaty, like, anxiousness.
Gotcha. So vasovagal, what that is, you have a nerve that is down kind of on your bottom, right? And so when you hold your breath, a lot of times when you're getting anxious, and you might see this with lab draws a lot, they'll hold their breath, or they'll bear down, right? So if you're like having a bowel movement, so if you bear down, it can definitely cause the relaxation and cause you to become hypotensive, and that's why people pass out. So yes and no. That's definitely something that if they're doing that, or they can definitely vasovagal per se. All right. So we talked about examples of stressors. So in your book, let's see, what page is that on? There's a couple of examples of physiological and emotional. Okay, so you can kind of get the idea of what each one is, right? And so 77, okay, perfect. Yeah. So just understand that there's two different parts, right? So pain is a big one, and most of our patients are in the hospital are going to have pain. They're going to have new diagnoses, and so we have to have that support. So we're always that first, person that is going to be able to intervene. And then you also, depending on where you work, may have resources to help them. So you may have, mental health providers, you may have case managers, you may have those type of resources, but a lot of times it's just going to be you, okay? So you have to be able to, tell me more about what's going on, those type of things, okay? So that you can send them to the appropriate person. All right, I have a case study here, and since let me try to share my screen with you guys again. Or actually, you know what, I think I have, hold on, let's see if I can do this. Oh, you're fine, Alice. Okay. Okay. All right, so can you guys see the case study on the screen?
Yes.
Okay, perfect. All right. Does somebody want to go ahead and read the case study?
I can read it.
Perfect.
JR
Go
is
for it.
46 years old. His doctor just left the room before you walked in. At first, he is quiet. After a few minutes, he tells you that his doctor just told him that he has type 2 diabetes and will require treatment and changes in his lifestyle. What can you say?
All right. So diabetes is a huge one, right? That's a whole lifestyle change. Not only with, your diet, right? Who wants to go on a diet and change all of that? Especially our diabetics, right? They have their lifestyle and they don't want to be told otherwise. But it's that, it's the physical, it's the medications. So there's a lot going on. That's a huge diagnosis. So if you get one of those patients, what's some things that you guys can say? What can you start that conversation off with? What would you do with him?
I guess if I was thinking about what I would say would be more or less like, I know it's going to be challenging, it's going to be a lot of changes, but it's going to benefit you because I'm sure if he didn't know that he was type 2, he obviously hasn't been feeling well. So like the changes in his lifestyle will only be for like his betterment. And so focusing on that, and then you can get into the details of what medications he'll need and what his daily routine is going to be like.
So take that a step before that one, right? Because that's him telling you what's going on in his fears. How are you going to even understand what his fears are, right?
Yeah.
Exactly. What does this mean to you, right? So you want to actively listen. So you want to like get his understanding of what just happened. Okay, so you need more information about his perception of the diagnosis. Okay, right. So that's really where you want to kind of start all of your conversations. What is the patient's perception? Because we probably know, right, that it's lifestyle modification, all of that stuff. But that might not be what's bothering him. It may be, how is he going to pay for this? How am I going to pay for all of this stuff? I have to have doctors. I don't have insurance. I'm sure I'm going to have follow-up. So that may be where he's coming from versus I got to change my diet, right? So we need to get a better understanding of what his perception is, okay? How does he feel about this new information, right? So being more of an active listener, right? Let's see, how is this going to impact your family? Again, it could be more of a financial burden, okay? And then what does he know about the diagnosis? Tell me what you know about diabetes, because there's a lot of misconception about a lot of things, right? And they may be completely uninformed, and that's what's really driving his stress and anxiety, okay? So we need to get a better understanding of what he knows about the disease. Perfect. All right. So, okay, I gotta figure out how to go to the next slide. Here we go. Okay, so factors that are affecting his response, right? So he's got a couple of things going on. So we talked about the type. So what type of stress is this? What kind of stress do you think that this is going to impact? Emotional, okay. Yeah, absolutely. What about the physiological part of diabetes? What do you think brought him to the hospital? Right? So if he's gone undiagnosed for a while, he may already have some, things going on that he just, it's already affecting his, his organs. Maybe it's his kidneys. Maybe it's his, he's got neuropathy in his feet and can't really feel them. Right, just feeling fatigue. So there could be some psychological parts to that too, right? Maybe he fainted, right? Because he was hypoglycemic, sure. So it could be kind of an example of both stressors, right? You can kind of put them into each category. Yeah. So duration. So we talk about acute and chronic. Okay. Do you guys know the difference between those two terminologies? And what would you say that diabetes is?
Chronic.
So it's a chronic disease, and that means that it's lifelong, right? It lasts longer than 3 months, and it's something that he's going to have to adjust and modify pretty much for the rest of his life, right? It's not something that really goes away. However, you could have an acute exacerbation of his disease, right? So what does that mean when you have an acute exacerbation or acute on chronic? You might see this in test questions. So know the difference. What does acute mean?
Is it a rapid onset?
It can be, yeah. So acute means it's happening now, right? I got this problem right now. So you can manage diabetes, right? So every day you're managing that chronic disease, you're taking your blood sugar, you're giving yourself your medication, you're watching your diet. So you're watching all the things to keep your blood sugar in check, right? So that's your chronic, the chronic, managing it, right? And then you can have an acute exacerbation. So let's say, what's his name? JR. Let's say he, got sick. He's got pneumonia. He's got an infectious process going on. That infection is going to drive up that blood sugar, right? So now he's got an unmanaged blood sugar that's in the 400s, and that's what's bringing him to the hospital, okay? So now you got a chronic disease with an acute problem, okay? So just some new vocabulary there that I think is important for you guys to understand. Right, Christian, exactly. So something that makes this condition worse for a short amount of time. Yep. So an acute problem, again, is something that's happening right now. And you'll notice this with your CHF patients, your diabetics, your COPD patients. So they're managing this chronic disease, right? Trying to, and then they'll have exacerbations when it's at its worst. And they have an acute problem that brings them to the hospital that we've got to fix, okay? Intensity, would you say that his intensity is mild, moderate, or severe? Okay. Right, again, it's that perception, right? So how is he dealing with that? How is he understanding that? Pain scale, I mean, you can ask them what their pain is, but if they're not having any pain, but they're having a more of an emotional factor to that, right? That stress response to that's really not, a pain scale is not appropriate for that, okay? It's more of how's the patient dealing with that. Look at his heart rate, look at his skin, look at his breathing patterns, that type of thing. If somebody was in a severe stress response, how do you think that they would look? What would that person look like? Would that be an acute issue that you're going to have? Exactly, a panic attack, right? They're having a severe stress response. You need to go in there and give them immediate direction before they pass out, right? Why would they pass out? Why do you think that would happen? What's going on with them physiologically? Someone's having a severe stress response. Hyperventilating, right? So they're going to be all over the place, right? They're just not, they might be tearful. They could be getting out of bed. They might have IVs attached to them, right? So they're at risk for hurting themselves. They're at risk for falling. We got to get their breathing under control. We got to really focus, and that's an acute issue, right? So someone that's having a moderate, they might be a little distressed, and we have some time. We can give them some relaxation techniques. We can refocus them, right? Make sure you get good eye contact, and let's kind of try to bring them back, okay? There's some things in your book. There's a table on page 82. It starts on 81. It talks about relaxation techniques, the relaxation breathing, okay? There's coping strategies, but again, there's a right time, right? So if you have somebody in a severe stress response? Are you going to tell them, okay, let's do there's a meditation, right? Imagery, those type of things. Is that the most appropriate time to talk about that? Do you think they're going to listen to you? Do you think they're going to focus on you? Right. So there's different, strategies that you can approach with the patient, but it has to be what's best for the patient at that time, right? So it depends on what intensity. So for JR here, I would say he's really in the mild, right? So he's just kind of like in shock, right? So he's not having any of the severe symptoms. It looks more like a mild. So is that something that you can sit down and have that conversation with, what we talked about before? Tell me what's going on. Tell me a little bit more about what you know about diabetes. Would that be appropriate? Yeah, exactly. All right, so let's go on to the next one. Okay, so you also got some other factors, right, that's in response to his stress. So you got those internal influences, right? So age definitely can affect that. So let's say you work with pediatric patients, right? Age is definitely going to affect how you approach this, okay? Their health status, are they normally healthy? Are they, capable and able to do all of their ADLs? Personality. So everybody has a different personality on their perception and how they're going to cope and how they're going to take that information, how you're going to educate them, right? It's going to affect those things, okay? And then you also have those external influences, right? So we talked a little bit about culture and religious beliefs, right? And so that's something that you definitely want to know about, right? So what's their culture's big with food, right? And so you have a new diabetic patient that you're telling them that they can't have the same foods that they're normally accustomed to. How is that going to work? You want to know more about that. And so that might be, something that he may not want to talk about with his family or want to change, how things work in their household, right? So that could be, you're involving more than just the patient. Now you're talking about the whole family. And so that can be lifestyle changes for everybody, right? You want to know more about that. So that can be definitely an external influence, okay? Social support. Do they have support at home? That's huge, right? If you have a patient that usually lives alone and doesn't have any family or friends or anything like that, how do you think they're going to manage this new diagnosis, right? Timing, they talk about timing a little bit and the number of stressors. So timing, right? We always feel like, and I know this happens to me too, it's kind of like, what's that saying? Everything happens at once, when one thing happens, it's just a cascade of bad events, right? It kind of feels like that sometimes, that black cloud that hovers. When it rains, it pours. Thank you. Exactly. So they could just be, this is just another thing, it could be completely unrelated to their health, but maybe there's things going on at home. Maybe they, the storm that just passed through blew their roof off and they don't have the money to support that. Now they got this diagnosis and how are they going to manage all of that, right? So it can be very overwhelming for patients. If you have, a patient in that situation, when you sat down, you talked to them and you kind of learned more about them and you found out all of these just bad events after bad events, and they just feel like they give up. I just don't know what to do. I can't financially support this. I have no support. I have nowhere to go. What do you think they're at risk for?
Depression. Yeah.
Absolutely. Absolutely. And even taking that a step further is, are they at risk for harming themselves? Are they kind of at that point? And and again, we're going to be the nurse. We hear it all, right? We're with our patients the most throughout the whole day, right? So you're going to be in and out of those patients' room, and hopefully you have conversations with them and just kind of get to know them and get to know, so you can better take care of them, so you can better educate them at the very end, right? So you're going to get to know your patients very, very well. And one of the things you got to be very aware of is, are they coping effectively? If they're not, and they make statements that, I just want all this to be over with, just and you know, they might make some very bold statements to you. And we'll talk about this in later chapters, but you know, reporting is essential for us, right? And so if we're concerned at all for somebody's well-being, that's something that you need to know more about. So try to dig a little bit deeper and figure out what they're talking about, what they're saying. But also, after you get that information, you're mandated reporters. Okay, so whether it be to you know, child protective services, adult protective services, or if we need a mental health evaluation. Okay, that may be something that's needed before they get to be discharged. Okay, it's something that you need to make sure that you're letting the physicians know that you're concerned with, because they may not talk to the doctors, right? They're in those white coats and they're in and out of that room in 5 minutes, and they're not going to have that relationship. Some doctors do, but for the most part, you're going to be that person that they know, and that they're going to confide in. So it's important that we really get to know what's going on. Okay. Okay, so let's see. All right, so we talked, you know, about buffers, right? So let's think about this particular case, right? So we're talking about JR here. Let's see. Sorry. So when we talk about those key personality, right? So we have people that are very resilient, right? So we talked a little bit about, you know, that patient in the one room who's very stoic, who's not going to show their emotions, right? Maybe it's a cultural thing, where they can be 10 out of 10 pain. They just had, you know, a big major surgery, and you know that they're in pain. You can see it in their vital signs, but their face is not showing it, right? They have that resilience and how they're handling their stress, right? Hardiness. So how would you describe hardiness? What's a good word for hardiness?
Stubborn.
Strong, right? Is that what you said? I'm sorry. Stubborn? Yeah. So hardiness is kind of a combination of three characteristics, right? So they like to turn things around. So they'll take a bad situation and turn it into a positive one, okay? So they may say, well, this is an opportunity for, you know, me to change my diet, my dietary habits, or, you know, I want to be really committed to this and having control over that. So they may be, you know, that may be what's that buffer for them for that stressful event, okay? Having a positive attitude, okay, being optimistic. So those are things that they cope more effectively with stress, okay? It reduces a person's chances for developing stress-related illnesses, right? They tend to recover more quickly from illnesses, okay? All right, so let's go move on to the case study again. So let's see, where are we at? We'll spend 5 more minutes on this case study, and then we'll take a break, and then we'll jump into chapter 7. So let's see. Sarah Clayton, do you want to go ahead and read this?
Yeah, sorry, I thought I had my mic on. My bad. You walk into JR's room after lunch. He says, I can do this. He asks for more information about diabetes and says his wife is coming to plan lifestyle changes they will need to make.
All right, perfect. So what do you think? Is that a good thing, or what do you think is going on there?
I think it's a good thing
Good, right?
because, yeah, because diabetes, if you help change your diet, it might help with your like sugar levels and stuff like that.
Yeah, absolutely. So anyone that says, yep, I can do this, all right, I got this diagnosis, I can do this. So that's a positive outlook on it, right? He's changing the tone here. And then he's asking his wife to come in so that they can make those plans together. Exactly, including the whole family is a good thing, right? He's got a support system. So he's got some great things going on for him. So how are the personal characteristics of resilience, hardiness, and attitude and being optimistic demonstrated by JR's response to his stress? So exactly what we just talked about, right? He's got a good positive attitude. He's going to turn things around. He's got this, right? He's open to it. He's using his resources with his family, right? Being flexible and adapting to new information. Let's see. What else is something that you see with that statement that he made? What is that showing?
He's accepted his diagnosis and is open to whatever changes he needs to make in his life and is being optimistic
Exactly.
about it.
Yep, exactly. He's not in denial, right? He's accepted what's been just told to him, and he's got the motivation and the support. So perfect. Very good. All right. So there's a in your book, it has this little map here, and I think it's on, let's see. It's on page 78 on the top, and it kind of talks, shows you kind of the interrelation of the body system, right? And so how the body kind of responds, how the stressor goes down to the central nervous system and what happens there. You don't need to know all this, but it's a good way to be able to see what's going on with your patient, so you can kind of be able to assess appropriately what's happening. Okay, so again, we talked about that mild, moderate, and severe response to stress. Where are they in that picture, and how are we going to help them manage? Okay, so again, we talked about appropriate times to talk to patients, to educate, to bring them back down. There's appropriate times to take them on that imaginary road, and let's talk about things that we can do to help them. So real quick, so in the nervous system, right? And so when you're talking about the nervous system, we're talking about the brain, right? And let's see, so it gives us some control to the responses of stress. Let's see. So the nervous system, so they can have the emotional behavior, they can have that survival and self-preservation, which means, are they able to, do they feel like fight or flight, right? And so a lot of people, they have that tendency to kind of ignore, right? Or are they gonna manage it head on? So that nervous system, kind of how their brain, how they're receiving everything is going to help them adjust to what's going on. So in JR's case, right, he took him a minute. His response was, I think he stared off for a minute. It was very quiet. And then he kind of came back and said, okay, I accept this. I know what's going on. And so he kind of dealt with it head on, right? He didn't go into denial and try to make excuses of, things that he can avoid, right? Let's see. So go through all of your readings when it goes through all of the the endocrine system and that type of thing. So go read through that. Let's see. So again, we talked about stress responses, right? And so give me a couple of examples of stress responses. So what's going to happen physiologically to the body, right? What are you going to see in that patient? And I think it's on increased heart rate. Exactly. So their heart rate's going to go up, right? So you might have your patient on the monitor, and the doctor's in there talking to them, and you're watching the monitor, and all of a sudden their heart rate's 120, and you go, what is happening in there, right? They're probably getting some news that they did not want. You have a diabetic patient, right? Exactly. You're going to increase their glucose response. Exactly. Increase respirations. They might get hypertensive. Yep. What about their oxygen? Talk a little bit about that in that severe case, right? GI, absolutely. GI is always one, right? upset stomach, causes all kinds of pain and gassiness, and they can have immediate diarrhea. They can start vomiting. So their oxygen might be affected, right, Kara? So you might not see their oxygen going low, right, but their oxygen consumption. So if they're breathing really rapidly and they're not able to kind of control that, right, so they're going to be hyperventilating, right, and so they're going to be blowing off a lot of that CO2. So that's what causes that. They feel like, one of the things that you'll see is, I feel like I'm going to pass out. I'm starting to see dots. My hands feel numb. My mouth feels numb. And you notice that they're hyperventilating. These are all symptoms of oxygen consumption. Their demand is not, their balance is not correct, right? So these are all the physiological responses that they're going to have to that hyperventilation, right? And so the best thing we can do in that moment, again, right, there's appropriate times, is have them focus on you or something and tell them that they need to focus on their breathing, okay? And we need to be with me, that type of thing, because we've got to get that down, okay? We talked a little bit about that fight or flight response, okay? So there's different responses in that we adapt to, right? And so to that acute stress. So whether or not that stress is physiologic or emotion, those are things that are going to happen, right? And so we have to be aware of it not only could be your patient, but it could be the family member of those patients, right? And so especially death, right? So we deal with death a lot in the hospital. It could be, somebody's wife that they've been married to for 55 years that just passed away. Now we got that family member becomes somebody that we're kind of watching, okay? Broken heart syndrome is definitely a real thing. I've seen it happen. We had a wife that just lost her husband. They just had his funeral, and she came in via EMS from the funeral with severe chest pain, and he just died of a heart attack. And so, she comes in and we put her on the monitor, and she actually looks on the monitor. Her heart is mimicking that she's having a heart attack. So we take her into the cath lab. The doctors go in and look at all her coronary arteries, and everything is normal. Everything is clear. What is going on, right? You would think, well, a heart attack is when you have blocked vessels. So there's got to be a blockage if she's showing that she's having a heart attack. It's called broken heart syndrome. And there's other terms for it, but basically it's stress-induced cardiomyopathy. So that all the stress that is just happening, it's an acute event, can actually dilate the coronary, not the arteries, but the chambers, right? And so, anyways, long story short is that her stress was so severe for her that it was unmanageable, that it mimicked a heart attack. Okay, so now we're taking, she did come in separately, but again, you might have that patient that passes away. It could be a child. Now you have parents, you have siblings that are coming in, so you got to be very, very aware of that whole response as a whole. Okay, so that's definitely a fight or flight, right? It's physiological changes that are important to a person's survival. This alarm system puts on a patient on high alert, right? So again, you need to know what's happening with the patient's physiological part as well too as their emotional part. Okay. All right, and then it goes into the immune system. Okay, it talks about acute on chronic stress can cause immunosuppression. Okay, so if they're at risk for infection, or they've already got a disease process and their immune system is compromised at this point, that can definitely cascade a whole lot of other events, right? So again, it kind of brings it, we have the understanding of what stress is and how people perceive it, right? And we read or understand how that affects their mind and their body, right? when it's appropriate to intervene and how we manage that, and then how the patients are going to manage that as well too, right? What their understanding is. It's all one, right? So mind, body, and spirit. And I think there's a picture on page 80 when it kind of gives you that whole mind, body, spirit, and all of that together can be either healthy or it can be an illness, right? If we have a bunch of stressors that are just kind of coming from every direction, or even one direction, if they're not coping effectively, can definitely lead to illness, right? And that's usually why they're in the hospitals, that they're not managing it appropriately, okay? All right. Let's see. Do you guys have any questions about stress and stress responses? There's some relaxation techniques, so I want you guys to go over that. Starts on page 81, talks about the relaxation breathing, okay? The biofeedback, there's meditation, there's imagery. Know what the differences are, okay? So I would definitely know if you're going to have a patient, and I'll give you a scenario, what's the most appropriate response for you to teach that patient at that time? Is it going to be relaxation breathing? Is it going to be meditation? Is it going to be imagery? Okay, and appropriate time. So put yourself in that situation, right? And say I have this patient who is having a severe reaction to or stress response reaction, right? Is it appropriate at that time to take them on an imaginary journey? Probably not. So know when it's appropriate, okay, and how you're going to manage that. Page 85, it goes over the stress nursing management and what you're going to implement, okay? So definitely know that. Let's see. And again, on page 86, table 6.10, I think this really hits it home. It's going to be, very difficult at times to be able to say the right things, right? Again, it depends on what department you're going to be working in. For me, my background was all ER when I was a bedside nurse, and death was huge, or people that are actively dying, and we have family member. And I would, you'd have to go and part of the, you want them to be as involved as they can. Back in the days, we never let anybody witness that. No family member ever came back when we were coding a patient or resuscitating a patient, right? It was part of the rules of the ER. We found out that that's not the best approach, right? Because it causes a lot of angst. And did we do everything that we could? The families don't know what we did, right? And so over the last 10 years or so, they've really linked the two together and kind of leave it up to the family member if they want to witness that. It's not for everybody. Okay, I don't think that everybody needs to see that, but there's some that want to. There's some that want to be next door and kind of at least know that the team is doing all that they can, right? And that's probably one of the hardest things part of one of the hardest things about nursing is finding the right words, okay? A lot of times you don't have to talk. It's just being there. It's just telling them that you're there for them and what can you do. So this one thing on there, it says, try not to be superhuman. You're not expected to make everything right. You're not expected to always have the right words. We try not to give false hope to patients because then they're going to look at you and say, well, you told me this, why didn't that happen? Okay, so again, tips for us as nurses to handling stress, okay? So read that little box there. I think that's important too, especially, you guys are coming into a nursing world or a healthcare world that's very different from what we knew, just a few years ago. The pandemic has definitely changed nursing and healthcare pretty dramatically. There's a new law into place, and if anybody's interested in legislation and fighting for patient rights and so forth, we were not letting patients in with COVID positive that were dying. So they were literally dying alone. We looked at it from a perspective of we're trying to protect the staff from, getting COVID, potentially, exposing unnecessary exposures is really what we were looking at. But imagine the impact on that, right? So having your loved one in a hospital that's actively dying, knowing that they're dying and you can't be there with them, it's absolutely devastating. Imagine that stressor, not only on the family, but the patient. They might be aware to some extent, right, of what's going on and knowing that they're dying alone. So it's been very stressful all the way around. So we definitely, as healthcare workers, need to take care of our well-being as well. It's super, super important. And know your resources, right? There's people that you can talk to within the hospital as well too, because if you're stressed, you're going to stress your patients as well. So it's just, it's not a good thing to be in. Okay. All right. Any other questions on stress, you guys? Stress management. You guys feel pretty good about it? Can you guys still hear me? Okay. All right. I want to make sure you guys are still there. So let's go ahead and take a 5-minute break. Okay. You guys go get something to drink, grab a quick snack or something, and then we'll go on to our sleep module and we'll kind of review that real quick. Okay. So come back at 11:18. You're welcome, Alice. All right, you guys, it's 11:18, so let's go ahead and get started on sleep and sleep disorders, okay? Have you guys had a chance to read and get caught up on that module yet? Do you read, Sarah? Perfect, okay. So sleep and sleep disorders. So sleep is super important, right? We have sleep cycles, right? We have what we're supposed to be getting, and each person's different on what they can function on, right? Some people can function completely normal on 6 hours. Some people need 9 hours of sleep, right, to be able to function. And that's really when we talk about somebody that has sleep disturbances, when they cannot function appropriately or, manage their day, right? And so it's kind of that state in which a person lacks their awareness of their surroundings. Okay, so is it inefficient sleep? Is it fragmented sleep? Are they not getting the good REM sleep? So there's different stages in the sleep cycle that can definitely cause, long-term side effects, or it disrupts their daily, their daily living, right? So when we talk about sleep disturbances versus sleep disorders, what kind of conditions do you think a sleep disturbance would be versus a sleep disorder? What does that look like? What's the difference?
I'd say like a disturbance would be maybe more of a one-time thing, where a disorder is more chronic and have to deal with more than that disturbance.
So yes, you're kind of on the right track. So it's just, they have poor sleep quality, right? It can be definitely chronic. So I'm one of those. I have chronic insomnia. I feel like I don't have any sleep disorder per se. Like I don't have narcolepsy or I've never been diagnosed with insomnia, but I just have poor just sleep patterns and habits, right? Doing a lot of work late at night, which then causes my brain to be overactive when I try to go to sleep. And so it's definitely chronic, but it's not a diagnosed disease or a sleep disorder, okay? So there's untreated sleep disorders, so chronic insomnia, obstructive sleep apnea, those type of things. If left untreated, can definitely cause health and safety concerns, right? What kind of health concerns would you think would be happening if somebody goes undiagnosed with poor sleeping habits or has a sleep disorder that they don't know they have?
It can affect their everyday life. Like they're not fully focused there. Like being tired, you can cause a car accident, just making wrong decisions.
Absolutely. Making decisions, right? So financial decisions, those type of things. So they could be completely impaired, right? Exactly. Impaired concentration, impaired memory. Okay. It can interfere with their work and social functioning, right? So driving while drowsy is related to 100,000 accidents and 1,500 traffic fatalities per year. So that's definitely a thing, right? So we have, I think, in the United States alone, you probably would want to look at the statistics. It's kind of scary on how many people use a sleep aid medication so that they can sleep, right? Because they have such a bad sleeping disturbance or sleeping pattern. If you're traveling far from work, right? If you're traveling late at night and you're trying to get home and you've got this problem, you're more at risk for causing an accident, right? So you're not only putting your safety at risk, but others as well. Okay. Let's see. Oh, somebody's not on mute. Okay. So the sleep-wake cycle, that's controlled by your brain. Okay, so there's all kinds of things going on that can definitely help that sleep-wake cycle, right? And so go in your book, it talks about the circadian rhythm, okay, that the psychological sleep mechanisms, right? So definitely go in there. It goes more into kind of the pathophysiology behind that. Understand it, know it. There's nothing that you have to like absolutely memorize or anything like that, but just definitely understand it, okay? Because it's going to affect your patients in the hospital, okay? So they talk about sleep disturbances in the hospital. You already have a patient that's compromised, right? So it could be, are they having whatever kind of issues that they're having? So they could be in there for a COPD exacerbation, right? They have chronic obstructive pulmonary disease. They already can't breathe. They're already stressed, right? They already have that stress response. If they're in the ICU or any unit for that matter, it's very loud, right? So if we disturb their sleep cycle, right, we're even contributing more to them not being able to fully engage in recovery, right? So if their sleep cycle is all disturbed, again, it can definitely affect how they're going to recover and how they're going to respond to that, okay? So insufficient sleep and sleep disorders, it changes the body function and health problems, right? So when you look at page 90, there's a little man that's there. Let me pull it up here. And it kind of goes over how effects of sleep deprivation, sleep disorders affect the body. Okay, let me pull this up here. All right, so if you're looking at page 90, it's in that top right corner. So when we talk about neurological changes, right, or sleep, the way sleep affects our body, we talked about cognitive impairment, right? So being able to make decisions. So being in the hospital, you need to be able to make decisions, right, for your own healthcare. And if you're not able to do that, who is going to do that for you, okay? Behavioral changes, so irritability, moodiness. I know when I don't get a good night's sleep and I got a lot of things going on, it's hard to concentrate. It's hard to focus, and you're just so tired. You're just trying to go through the motions. So again, with our patients, you can notice that they might be very irritable. They might be very moody, and that's something you got to look at. Are they getting enough sleep? Are we taking the best care of them? Okay. We talked about the immune impaired function, right? So they're at risk for developing infections or not fully being able to recover from, whatever disease process is going on with them, what brought them to the hospital, okay? Respiratory wise, if they have asthma, they can have exacerbated asthma during their sleep, okay? Heart disease. Heart disease is huge. We'll talk about sleep apnea here in the later part of the chapter. But if they have sleep apnea, that can definitely affect long-term health for these patients, okay? One thing that it does cause is it causes cardiomyopathy or an enlarged heart, right? So they're, and again, we'll go over that here in just a little bit, but definitely heart disease, right, or cardiovascular. So it can cause hypertension, it can cause dysrhythmias, right? Those type of things. It talks about stroke as well, okay? GI. So GI, they're at risk for increased obesity. They're at risk for GERD. In the endocrine system, they're at risk for type 2 diabetes, insulin resistance, and growth hormones. So you can see it can definitely affect so many different parts of the body when you don't get good enough sleep, okay? Super, super important. So sleep disturbances in the hospital, okay, especially in the ICU, is associated with decreased total sleep time, okay? So if you look at the circadian rhythm, we're going in there all the time, right? We're disrupting their sleep cycle. So they're not really getting that full sleep of what they need in order to, be healthy and help them recover. There's a lot of noise, right? There's alarms, there's activities, right? What else is going on what are we doing in the hospital that disrupts that sleep? That's one thing you can imagine. If you're working at night, what are you doing? The lights, testing, constant in and out for vitals. Yep. Assessing your patients, right? All those alarms going off. And then we have ancillary, right? So it's not only nursing, but you got, your techs, you got radiology, you got lab, you got dietary. I mean, Imagine if you feel like you're going in and out of that room a lot, and then you've got ancillary staff on top of that, that patient's not sleeping at all. You know, they're just not sleeping. So insomnia can be characterized as difficulty falling asleep, difficulty staying asleep. You wake up too early. You wake up just feeling overall unrefreshed, right? You just don't feel like you really got any sleep at all. Like, what happened the last 8 hours? Because I don't feel it. Okay, just overall dissatisfied with the quality and the quantity, right? So to say you have insomnia or to be diagnosed with acute insomnia, it's difficulty falling asleep or remaining asleep for at least 3 weeks a night for less than 1 month. Okay, so I could probably diagnose myself. That's me, and I'm sure some of you are experiencing that just with nursing school in general, right? A lot to do, a lot on your mind, probably having a lot of difficulty falling asleep or staying asleep. And you might have the complete opposite, right? You might be so tired by the end of the day that you're getting the best sleep of your life. So it could go either way. Again, we talked about behavior changes, right? We talked about lifestyle changes. So there's medication. So let's dive down just a little bit with behavioral changes, okay? So what are some things that can definitely affect behavior-wise with your sleep patterns? So, I mean, what are we doing? What behaviors are we doing that will affect our sleep? Coffee, right? We drink caffeine towards the end of the evening when we're trying to wind down, right? Computer and phone use, absolutely. That's a huge one. Lights on, technology, right? What about taking naps during the day, right? What if you take the best nap you ever had that was 2 hours long, right? About 5 o'clock at night. It's definitely an effect, right? What about exercising? What's the most appropriate, if you're trying to make sure you're getting good sleep, what's the best time to exercise? In the morning, right? So would you exercise right before it's time to go to bed? Absolutely not, right? Because you got all those endorphins going. So it's not advisable to exercise right before bed, right? What about jet lag? Jet lag's huge, right? Especially if you're going, you know, either way, actually, if you're going, if the time changes ahead or behind, right? Your rhythm's going to be all messed up. My husband was in the military and we lived in Hawaii, and so we would fly back home to see family every now and again, and that was a huge. I think it's like a 7-hour time difference, right? You can imagine the jet lag that we had trying to be on everybody else's schedule. We're supposed to be, it's 2 a.m. at home and we're trying to be sleeping, right? So that can be a definite factor, especially someone that travels frequently, maybe for work or something. Yeah, time zones are definitely something, definitely that causes that insomnia. Just everyday concerns, absolutely. So lifestyle. So what about lifestyle? What are we doing with our lifestyle that could definitely affect the way that we sleep? Drinking, yeah, alcohol. What else? Activity levels, okay. So nicotine's a big one. Stimulants. So those type of things can definitely affect. So we have a large population of patients that are on medication to help with like ADD, right? And so that's definitely a stimulant medication. So are they taking that appropriately? Is that something that we need to re-educate them with? Are they taking it in the mornings? Are they taking it too late? That type of thing, okay? What about medication side effects? There's some medications that we take that definitely can stimulate, their sleep patterns as well. Steroids is one that definitely will give somebody insomnia. So are they on steroids? When are they taking it? How long have they been on it? Those types of things, okay? Pain medication, right? So if they're on pain medication throughout the day to try to control something, they may be sleeping more than normal, right? Causing drowsiness, right? So those are some things that we can look at in their health history, okay? So there's a couple other on table 7.1. There's relationships with sleep disturbances to diseases and disorder. So let's see, what page is that on? That was just a little map that shows who's getting 7 hours of sleep or more at night. Not important to know. Okay. Oh, it's on here, 7.1, sorry, it's on page 91. So there's a whole list of diseases and disorders when it talks about cardiac, heart failure, those type of things, and the sleep disturbances associated, okay? So again, this is something that's important. These are gonna be your patients in the hospital, okay? And it's important for us to know how we can help or how we can improve the patient's sleep cycle in the hospital, okay, or or wherever you're working, wherever you decide to work, okay. Let's see. All right. So we talked a little bit about the manifestations, right? We talked about difficulty falling asleep. We talked about the frequent awakening or the fragmented sleep, prolonged nighttime awakening. So they might just wake up and then stay awake for 2 hours and then try to fall back asleep. And then when you finally wake up for the morning to start your day, you just don't feel restored, okay? There's diagnostic studies for insomnia, okay? It can be self-reported, so a good thing is to keep a log or, screening of how they're sleeping and what that looks like so they can take that to their physician. There's a couple of other different testing modalities that they can do to monitor brain activity, muscle tone, and so forth. So I would definitely know what those tests are available and how we can, that they're available for our patients. So let's go, I'm gonna put a question up here for you guys. Okay, here we go. Okay, so does somebody want to read this for me?
I can read it.
Go for it.
A patient at the outpatient clinic reports insomnia and anxiety. He tells you that he has recently lost his job and is unable to pay his bills. What response would be the most appropriate?
So you guys go ahead and answer in on the chat on the side. Is it A, you're healthy and you'll be able to find another job? B, can you tell me more about what's happening in your life? C, if you stop focusing on your problems, you'll be able to sleep better? Or D, you received a severance, did you receive a severance package from your employer? Hopefully everybody chose B, right? Tell me more about what's happening in your life, right? What's going on? Why are you having trouble sleeping? Why are you anxious? Absolutely. All right. You definitely don't want to say, oh, it's okay, you'll find another job, because that's kind of dismissing the problem, right? We don't want to be dismissive. Okay. So what is our goals when we have a patient with insomnia? What is something that we can do to help our patients make changes? What can we do? Yeah, don't give false hope. Definitely not. It always comes back to you, I promise you. So somebody has chronic insomnia and it requires a more in-depth cognitive behavioral therapy, right? So there's a couple parts to that. Right, turning down the lights. How can we help better our patients get on that cycle, right? So let's turn down the lights. What else can we do? It's a couple key points within the hospital that we can do, that we can control. Try to get them on a routine, okay? Right, cluster our activities. So let's see what we can kind of group together If we got to give meds and we got to do an assessment and we got to, do vitals and so forth, let's all do it at one time. Okay, let's hit them all at once and then leave them alone. So absolutely, if you can do that, that's awesome. And something else we can do. We kind of talked about a little bit earlier. I think maybe ask them what they would prefer. And Kara, what do you mean by that?
Sorry, I realized that was really confusing. My apologies. It made sense in my head. I was thinking we
Kind of
can
know where you're
ask
going,
them,
I think.
like, right? Yeah, like maybe like, hey, what is most, because I know for myself, lights don't really bother me, but noises really do. So I could, maybe we can adjust like that way, like what is the most disturbing thing that's causing maybe the most disrupt here for you? And then we can kind of adjust where we can, of course, within
Yeah.
reason.
Absolutely. Yeah, that's a great point. So it kind of goes back to that question, what's bothering you the most and how can I help fix that, right?
Yes, I just think communication and honestly just like
Mhm.
we've been saying, active listening is just so important because a lot of people I've learned just, being a customer, just people just, in general, people just really like to tell kind of what's going on and that
Mhm.
makes them feel better too, just feeling heard.
Absolutely. I think you hit that right on the nose. Absolutely. So turning the TV off. Absolutely. So that's another good thing. So let's turn the TV off. Let's kind of set the tone, almost like, you're taking care of one of your kids at home, right? And so let's set that tone for it's time to go to bed. Okay. Turn the lights down. Maybe shut the blinds if you're, in a metropolitan area where there's a lot of lights outside or something that could be affecting that as well. So let's shut the curtains or the blinds, right? Um, can we decrease some of the noises in the room? So maybe not have alarms going off inside the room, but keep them on the monitor outside, right? That could be something that we can do within policy, obviously. What about, turning down the lights out in the hallway? Some units definitely will do that. They'll have like quiet time. And so it'll be no visitors during a certain amount of time so that the patients can definitely rest, right? Because when we have visitors, it causes them to stay up and, it can be a stressor for that patient. So let's get rid of the, let me take that back. Don't say get rid of, but maybe, have them have their own downtime, right? A cooler environment, right? So we can turn down the temperature in the room. Yeah, if they're stressed before bed, they may be practicing breathing techniques or something to reduce stress at night. Absolutely, that's a great thing too, Christine. I like that. No caffeine late in the day, right? So there's a lot of things that we can do independently, right? That we can help them kind of get that environment that they need to be able to sleep. Okay. We can encourage them. So if they have insomnia, sorry, I don't know if you guys can hear my phone ring. I can hear it on my AirPods. So I apologize for that. Let's see, where was I at? So encourage not to read or watch TV. Okay, limit naps. So hopefully, they're not napping throughout the day, which is really hard, right? So if you have a patient load of, 5 patients, it's really hard to be able to control that sometimes, but you can let them know, let's try to stay awake, maybe put them up in a chair, okay? Give them activities throughout the day. Can PT come in and help ambulate through the halls? Do they need that? Can they walk on their own? Do they have like puzzles at the bedside, that type of thing, and keep them going throughout the day, keep their mind on something a little bit different. And again, it's appropriate, right? There's going to be patients that can't do that, and there's going to be patients that can. So making sure that we're doing that appropriately. Avoid exercises several hours prior to bedtime. So obviously most of our patients aren't going to be exercising in the hospital, but this is something that we can help educate them when they go home. Okay. Avoid large consumptions of meals, alcohol, and stimulants. Okay. Manage their worries. Yes, absolutely. Okay. So on page, let's see, table 7.4. So there's some drug therapy. You guys should be getting, you guys have pharmacology. You guys have already been attending, correct? Okay, perfect. So these drugs should be what you're also learning in pharmacology. So I would definitely know these medications, okay? Have an idea, there's drug like the benzodiazepines, okay, categories, and then the medication underneath that. So kind of know what those are. There's not going to be any specific drug that we're asking you on any of these tests, but it might be the patient's on a benzodiazepine. How are you going to effectively, manage that patient or so forth? So I would definitely have an idea of what the medications are and what they're used for. Okay, so know that, and it's a small little table, and it's on page 93. Right before that, there's a sleep hygiene table on 7.3 about patient teaching. Okay, we went over all of these things just a minute ago, what we can do to help teach our patients, okay, who have any kind of sleep disturbance. Okay, what to do, what to avoid, those type of things. Let's see. So let's go on to the sleep disordered breathing. Okay, so I think that is on, let's see. On page 95 is where we go into the obstructive sleep apnea. Let's see. Yeah, so on 94, it goes over, the nursing management, the diagnosis, and implementation. So if you go back to your, in Blackboard, there's the outcomes. These are things that you want to focus on, okay? So the nursing assessment, what are you going to be looking at in your patients? How are you going to diagnose them for your nursing diagnosis, okay? And then how are you going to implement your care, okay? So those are 3 areas I definitely think that you guys, when you're reading them, is make sure you understand, okay? Because this is what we're going to do as nurses, how we're going to approach our patients, how we're going to care for our patients, okay? Then right below that, it goes into sleep apnea. So when we talk about sleep disorder breathing, right? What's one thing that's very common that a lot of people do when they sleep? Snoring, yes, definitely. So that can definitely impede their normal sleep pattern, right? So a lot of people, if they snore, they're either, they could definitely have sleep apnea, right? That can lead to that, but they can also have periods of apnea, right? That's part of sleep apnea, where they actually stop breathing, okay? And their body kind of startles them into where they make themselves breathe again, okay? And that goes on throughout the whole night, right? So that can definitely be dangerous. But yes, snoring. Let's see. Apnea, so temporary cessation of respirations, right? So they stop breathing. They can have a temporary restriction of respirations without a full cessation. An increased respiratory effort leading to frequent arousals. So you might see somebody kind of startle themselves, are they snoring? Are they having a period of apnea? That type of thing. So if they have that frequently throughout the night, they're definitely have a sleeping disorder, okay? And then we talk about obstructive sleep apnea. It's the most commonly diagnosed sleep disorder problem, okay? So you might hear it called obstructive sleep apnea. You might hear it called just sleep apnea. So there's different ways you can address that. And basically, again, we talk about apnea, right? The apnea part is a sensation of spontaneous respirations. So if you watch somebody as they're sleeping and they have, they might have a snore with it, right? And then you look at them and they're like, where's the next snore? Where's their movement? And they're not doing anything. And it can last for quite a while, right? That's considered apnea. They're not having a respiration within 10 seconds, okay? They can also have very shallow respirations, okay? So they're not really getting that good airflow, okay? Not oxygenating the way that they need to be. And it can definitely startle them and wake them up, right? We have all these auto responses within our CNS system that says, hey, you're not breathing. We need you to take a breath, right? Those type of things. So what is obstructive sleep apnea, okay? Can somebody Can somebody describe or read out of the book what obstructive sleep apnea is called? Or what is it? What's basically going on?
It's a partial or complete upper airway obstruction during sleep.
Right. What's being obstructed? So when you look at the anatomy, right? Right. So their airway is being obstructed, right? So if you look at the anatomy of let me turn you guys to this page. I'm going to skim through these pages really quick. There's a model on 7.4 at the very top of 96, and it talks about what occurs with a patient with sleep apnea, okay? And so their muscles in the back of their throat relax, okay, and it allows the airway to close. So the lack of airflow results in repeated apneic episodes. What does apneic mean? Do you guys know what apneic means? And it goes in with that sleep apnea. Somebody has sleep apnea, they're apneic, they're not breathing, right? The periods of long episodes of not breathing, okay? Right. So they have a repeated apneic episodes, okay? So if you look at the back of their throat, right? So somebody's lying flat, that tongue in the back of the airway relaxes. And so if you look on the picture on B, it obstructs that airway, right? And so that's what causes somebody to be sleep apneic. How we manage sleep apnea is that the patient has to be on CPAP, which you might have heard, right? It's that little device that goes, it can cover their whole entire nose and their mouth. They have new devices that just go into the nose, but it's CPAP means continuous positive airway pressure, right? So there's always air or pressure going in to keep that muscle away from collapsing, right? So it keeps that airway nice and open, right? So that's the management for somebody that has sleep apnea when they sleep, because we can't control that when we sleep, right? It kind of splints the airway, preventing obstructive airflow obstruction. Okay, so again, you're going to have patients in the hospital that, or just wherever you decide to work, that have been diagnosed with sleep apnea. They know they have it. They have the machines at home, and they don't use it. Okay, so they're not helping the problem. What do you think is a long-term side effect if somebody that has long periods of apnea, right? Not only how it's going to affect their sleep patterns, but what do you think is happening in their body with the rest of their organs if you go for a long period of time without breathing? What do you think that's going to affect? Their brain, yeah, oxygen to organs, right? We talked a little bit about, there was a whole, let's see, where was that at? On figure 7.3 on page 90, we kind of went through the systems, right, of sleep disturbances in the hospital, and sleep apnea. Is it listed on there? But there's different things that just sleep deprivation in itself can cause, right? And so you can imagine if you're having long periods of apnea over a long period of time, we're talking, not just weeks or months, but years of this happening, and you're not intervening or using your CPAP machine, it's going to definitely affect your heart, right? Your heart's going to have to work a lot harder to pump that oxygenated blood where it needs to go. So that's what happens over time, is that patients develop an unknown cardiomyopathy, or they have an enlarged heart, and they don't even know they have it, right? Because, oh, it's just a sleeping disorder, I just can't sleep, it's not affecting me. They don't think it's affecting them, but they have that underlying disease. So that's why it's super important that we educate our patients, right, to say, if you have this, it's not only helping you sleep and get that, that rest that you need, but it's also help protecting your organs, okay, because you're going long periods of time without breathing, okay? So yeah, it can definitely affect a lot of different things. If you look on page 97, there's some pictures of different devices. In the hospitals, we really encourage patients to bring their own devices because it's specifically for them. They get very used to and accustomed to them, right? We in the hospital most of the time carry what's on picture C, right? It's that whole big old mask. It covers like half their eyes. It's on their forehead. I mean, it's just like a whole nightmare, right? People hate it. They hate it. They feel like they're suffocating. So that's what we have to offer, and so that's what they have to wear. They have to wear that, right? And a lot of what happens is they take them off. So you have this machine beeping, this patient that's having apneic moments, and so it just becomes a big mess. So we really need to educate our patients on the proper first being diagnosed. Okay, are you having these sleep issues? Are you having where you're not feeling like you're waking up and feeling rested, or those type of things. And maybe they need to just get tested. Maybe they need to go have a sleep apnea test so that they can see if they do have this, right? And if they do, then there's these devices that they need to be wearing to be able to manage that so they don't have any complications. So it's identifying the issue and then getting tested and then managing it. Okay. And a lot of times, so obesity definitely can affect or make it worse, right? Because they have more tissue in the back of their throat, okay? That tends to collapse a little easier. I did bariatric weight loss surgery for a little period of my career, and we had patients that rapidly lost a lot of weight, and they actually were able to get rid of their sleep apnea diagnosis and get rid of their machines just from weight loss. So there's a lot of things that can affect it. It's not 100% always that, but there's definite things that they can improve to make things easier for them. Okay. So the anti-sex machine, and most definitely, it's very not appealing by any means. It's pretty invasive, to be quite honest. Literally me constantly reminding my grandma, yep, absolutely. I'm sure if you know somebody that has sleep apnea, they have a machine and they probably do not use it. Would we ever encourage an apnea patient to sleep on their side or change their sleep positions? You can, absolutely. Changing positions may help, but people tend to it's that tissue in the back of the throat that we're talking about, right? So it relaxes. So even if you're on your side, that if that tissue is relaxing enough to the point where it's obstructing, it's not going to really matter how they sleep. Some people can, they tend to sleep upright or sleep like in a chair if they have really bad COPD on top of sleep apnea. It just helps them. Using 2 pillows to help sit up more. It can help, but it doesn't really get rid of it. So you really have to have that positive airway pressure to keep that, they call it a splint. So splinting the airway so that air is always constantly in there to keep that tissue out of the way. So yeah, it can definitely help. So, okay. All right, let's do another case study. See where we're at with time. We have a couple more minutes. We're almost at the 12 o'clock hour. See how fast time goes by when we're in lecture. So let's do this case study, and then we'll be done. Okay. So you have a 52-year-old man who enters his provider's office with his wife. Okay, she's concerned because he seems to stop breathing in his sleep. He weighs 280 pounds and drinks alcohol regularly. So based on what's going on here, what we're told, what are things that are symptoms that his wife noticed during his sleep that concerns you? What are a couple of things that his wife notices during his sleep? He stops breathing, right? And what else? Well, yeah, he stops breathing. Okay. All right. So what symptoms does the patient know? Let's see, hold on. Okay, so what are some things that his habits, right, that he can modify? So we have some modifiable risk factors here. What are those things? His weight and his diet and his drinking, right? Exactly. So those are things that we kind of take note and we can say, okay, These are things that he can change. Okay, so the wife's concerned that he's not breathing, or he stops breathing when he sleeps. Okay. All right. So again, we talked about manifestations, right? So frequent arousal during sleep. We talked about insomnia. We talked about that daytime sleepiness. We talked about snoring, irritability, those type of things. Okay, so those are the symptoms that sleep apnea can affect. So what risk factors does he have for sleep apnea? Overweight and his alcohol use, right? Okay. So losing weight can help definitely decrease that tissue in the back of the throat, right? To help that airway not be so obstructed. What will alcohol consumption do? What will that help him with? We talked about that earlier. Better REM sleep, better sleep quality, right? Yeah, exactly. It's not really a stimulant, but it doesn't let you sleep. You might think, okay, so when somebody drinks a large amount of alcohol, right, they go and they pass out and they think they're getting good sleep, but they're not getting the circadian cycle that they need to. So that's really where it comes down to the alcoholism, right? Is that they're not getting the quality or the REM sleep, right? Christian, yes, it can definitely. So alcoholism can definitely lead to damage in the throat, and I think you'll go over that later on in like either J2 or maybe further on, but yeah, definite changes in the structure of the throat for sure. Okay, so let's see. So, okay, let me switch here. All right, so complications, we talked about that, right? So hypertension, we have some cardiac changes. We talked about cardiomyopathy. He could have, changes in his rhythm, those type of things, right? So poor concentration, poor memory, that's the CNS part, right? It can also cause impotence in males, and then depression, okay? So diagnosis is based on the medical and sleep history, all right? So going back to the case study, so based on the potential complications of sleep apnea, what assessment data will you obtain on this patient? So what are you gonna look at? When you assess this patient that just came into the clinic, what are you gonna assess? Blood pressure, right? Heart rate. Okay. So basically your vital signs, right? So you're gonna do blood pressure, heart rate, what the rhythm is, maybe his oxygen saturation, right? What is he normally at right now during his waking hours, right? What's he normally at? We talked about his weight. What do you want to do with his weight? It's an assessment we can do with his weight. We can talk about his diet, but we're doing an assessment right now. So we're looking physically at him, his BMI, right? So what is his BMI? Is he considered overweight? Is he considered obese? Is he extremely obese? So you calculate that based on height and weight, right? So you're going to want to assess the patient's height and their weight, and that will calculate a BMI, okay? So basically our assessment on what we have is we know he's overweight, so we need to get a height and weight on him, and we want to look at his vital signs based on this previous slide here, right? Complications that can result. So we're going to look at these things right here, okay? All right. So what patient teachings could be beneficial to this patient at this time? So what are you gonna teach this guy? Exercise, right? Healthier diet. Maybe we can refer him to some type of weight loss program or nutritionist. Absolutely. Maybe he has no idea that he's eating it incorrectly, right? It's just what he's used to. Absolutely. So yeah, suggest a sleep study, right? So you got some things going on. Let's see if we can, get you a diagnosis here. Let's monitor that. Reduces alcohol consumption. Exactly. So, that's that's a hot topic. What if he doesn't want to change his alcoholism? What's something that you can teach him that will help him sleep? Exactly. Don't drink close to bedtime. So try to, give it about 3 or 4 hours before your bedtime so that you can get a better night's sleep. Okay. But definitely stopping it is going to be your number one, or decreasing the consumption is going to be your overall goal, right? And then we can also teach him maybe sleeping on his side, right? We talked about that a little earlier. It may help, it may not. It just depends on what his anatomy is and all of that. Okay. So, and some people, they might be able to say, yeah, I can sleep on my side. I have a sleeping pattern and I just can't sleep a certain way. I can start off that way, but I end up where I want to be, right? And so that may not be a solution for them. Stress for constant CPAP use. Brandon, what do you mean by stress for constant CPAP use? Yeah. Well, okay, stress the importance. Yeah. So he doesn't know he has it yet, and he probably doesn't have the machine. So I think that's definitely important once he's been diagnosed. But yeah, most definitely can't stress that enough, and we probably should be teaching all of our patients that, right? All right, so your nursing management, right? So we have mild sleep apnea. Okay, so they have very mild case of it. So maybe sleeping on one side can definitely help. Maybe elevating the head of the bed can help. Avoiding sedatives and alcohol 3 to 4 hours before bed, weight loss, and then using their oral appliances. So maybe they have, some type of device that can help them, that they've been prescribed in the past. Okay. Okay. We're almost done here. If they have severe sleep apnea, right, so greater than 15 apneic events within an hour, or decreased shallow breathing within an hour, that's considered severe, right? So these patients need the CPAP device, okay? It's very effective. We talked about that splinting and how it kind of keeps that airway completely open, but there's poor adherence to it, right? We talked about all the barriers. We talked about it being uncomfortable and feels like they're going to suffocate. It's not very, user-friendly in the bedroom, that type of thing. So they might be embarrassed to use it, that type of thing, okay? You also have a BiPAP machine, right? So it's a bi-level positive airway pressure machine. So they kind of have the same concept, and you'll learn more about that in your other modules, but there is a little bit of a difference, okay? So there's CPAP is the most effective, but they can also use the BiPAP as well. Hospitalized patients with obstructive sleep apnea, we got to be cautious when we use narcotics and sedatives, okay? So we can relax them so much to the point that we encourage that apneic instance, right? Okay. So if they use it at home, we need to make sure that we're using it in the hospital. If they should be using it at home, we need to make sure we're using it in the hospital. Okay. All right, so we talked a little bit about the devices. You guys looked on that page. So again, just kind of some different modalities on how they can use it. Some people have their preference, and there's even more than this. The one that goes in the nose, there's something that's even smaller than that one on the B. So just know that there's different devices. Okay. We're going to stop here, but definitely go on. There's surgical interventions, so just know what those are, know the words, and know what those are in case you have a patient that had one of these procedures. Okay. There's on page 98, there's some older adult considerations, so look at that too. There's definitely with all of these modules and chapters, there's going to be considerations for the geriatric population. Okay, so they're more at risk and more susceptible for different things because of what their body can tolerate. So I would definitely go over that. Okay. There's special sleep needs for nurses. Okay. We need our sleep as well. Especially if you're working night shift, that's really, really, really hard, and causes definite sleep disturbance and messes up your circadian rhythm, right? So go over your test questions in the back of the book, right? In your resources. I'm gonna help you guys. I need to get those case studies loaded correctly onto Blackboard and then your ebooks. But you guys have your books currently, so make sure that you're going in and reviewing. I think these case studies are really helpful. It helps you go back into your readings and pull out the information, okay? And just familiarize yourself. I'm sure there's a lot of new words that you're learning, new vocabulary, so it's very helpful to just kind of go back. And if you're reading something and you don't know what it means, Google it, okay? Try to get an understanding of what you're reading. It's not just about what you're reading or how much you're reading, but being able to put it into perspective, right? Always picture yourself with your patient so that you can be able to kind of walk through that. You know, what does that look like for your day? What does that look like for a nurse, okay? All right, you guys, I gave you a lot of information. Y'all have any questions? You're welcome. All right, well, that's all I got. So you guys are free to go. And don't forget that you guys have your quizzes due on Sunday night, okay? Oh, next week, I'll send an email to you guys just to let you guys know, but it looks like you guys are busy mostly on Mondays and Tuesdays, so I think we'll proceed with either a Wednesday or a Thursday class for now, okay, until the rest of you guys get your clinical schedules. So I think Wednesdays and Thursdays are going to be our days. All right, you guys have a good rest of your day. Oh, so on Thursday you got sim from 9 to 12, sim lab? Okay. And then Wednesdays, oh, Wednesdays 9 to 12, okay. Okay. All right, you guys, well, have a good rest of your week. If you have any questions, email us, let us know. You're welcome,
I
you
have
guys.
one quick question, sorry, before we leave.
Yeah, absolutely.
Sorry, okay, so I was doing the quizzes and it gives you 2 tries. However, you're accepting the first attempt only, correct?
Correct, yep. So your
Okay.
first quiz is always going to be your grade. That's in
Practice.
the grade book. Yep.
Okay, got it. Thank you.
You're welcome.
I have a question. One of the students messaged it in the chat box. Are our tests going to be case study based? Are they going to be related to how we do like the Swift rivers or
No,
like
so the testing, yeah, your exams will be multiple choice. Okay, so it'll be A, B, C, or D, that type of thing.
Okay, thank you so much.
Yeah, you're welcome. So you guys may have heard that the NCLEX is getting ready to change how they test and so forth. So you'll be learning more of that later on. But as you progress through the program, testing will get a little bit different. So for right now, for J1, it's going to be multiple choice.